We're going to discuss hematuria now, various diseases that can have hematuria. We'll start off with a very common one and a very common one on the exam, and that is the acute post-streptococcal glomerulonephritis. Look for, again, a prior infection with strep. It can be either throat, like a strep throat, or it can be also a skin infection like impetigo. There are nephritogenic strains of strep which you can get infected with them, and then later on they can cause kidney problems. And this is kind of like an autoimmune response a few weeks after infection. Usually you see it at about 5 to 12 years of age. That's not a coincidence. We already talked about strep throat, and we said the peak age for that is about 5 to 15 years of age. We discussed that that can cause rheumatic fever. Well, it can also cause glomerulonephritis, and that's the peak age for strep throat. Usually it's about a couple of weeks after a throat infection, or 3 to 6 weeks after an impetigo or streptococcal skin infection. It starts off with asymptomatic hematuria. They will describe cola-colored urine or blood in the urine. And look for the triad of hypertension, hematuria, and edema. Those three things, they're going to either mention it or give you lab results or something, and you're going to put that together to start formulating your diagnosis of glomerulonephritis. A urinalysis is a nice screening test because that's where you're going to see red blood cell casts. They may have an anemia on a CBC, and this is very important. A C3 is indispensable, and it will be low. When we talk about nephrotic syndrome, it's going to be normal, but it's going to be a low C3, so you need to do some complement studies because it is an autoimmune disease. Get a C3, and you will see that it's low. Think of glomerulonephritis. Also, you need previous evidence of a previous strep infection, such as a positive throat culture or a positive strep screen or elevated anti-streptolysin O titers. Okay? The best test to diagnose a previous infection would be the DNAase. Okay? So use your anti-DNAase. That would be the best test available. You can do your ASO titers and things like that, but look for the anti-DNAase as your best test. That gives you, sends you towards a post-streptococcal glomerulonephritis pathway. Complications include hypertension. They usually have acute hypertension. Most patients with glomerulonephritis, about 95% of them will resolve with time, so that the hematuria goes away, the edema goes away, the hypertension goes away over time. Very few of them will have serious or chronic renal problems. Certainly you need to give them antibiotics so that they don't pass that strain on to somebody else, and then they're at risk to get the disease. And during the acute phase, or even while it's needed, if it's, the blood pressures are high, then you would treat the hypertension. Other glomerulonephritides include Berger's disease or IgA nephropathy. This is the most common of the chronic glomerular diseases. This is usually, it starts out, it's progressive. You don't start seeing symptoms or problems till much later, and in these patients the the C3 will be normal. Alport syndrome is a hereditary nephritis. It is X-linked dominant, so that means that even though it's sex-linked, girls can get it because it's dominant. Usually females have just subclinical hearing loss. Look for hearing loss. You'll be reading the test question, and it might say that a little boy is sent home with a note from the nurse at school because he failed a hearing screen, or because the urinalysis showed some proteinuria and hematuria. And then it might mention that the boy has some uncles who have had hearing loss. Think of Alports. They have also at higher risk for cataracts, and just a key word that might be mentioned in the exam is foam cells. Girls, like I said, will have just some subclinical hearing loss and not progress with renal disease. Hemolytic uremic syndrome, this is a common one to get asked on the exam. It can go under gastroenteritis, under the GI chapter, because many times it follows a gastroenteritis, but it will have renal manifestations. This is the most common cause of acute renal failure in children, and it is going to be characterized by hemolysis, which leads to anemia, and it can also have kidney disease, which leads to the uremia. they also tend to have low platelet counts or thrombocytopenia. It's usually from the E. coli 0157, H57. This is the one that's associated with undercooked ground beef, not steak. Okay, remember the E. coli on the steak is living on the surface of the steak, so when you put the steak on the griddle or on the grill, you're killing it. What happens with the hamburger is it gets mashed up, and now the E. coli can be in the center of the hamburger, and that's why undercooked hamburger could be a source of this. And so hamburger should be at least medium well. It can also occur without the E. coli many times after a patient is recovering from a nonspecific viral gastroenteritis. The patient now starts to have decreased urine output. Sometimes you'll see that they get pale from the anemia, and you'll start seeing thrombocytopenia, and they can actually go into kidney failure. They may have bloody diarrhea. The labs show a hemoglobin of about 5 to 9. Look for the description, helmet cells or Burr cells on the peripheral smear. Those are nice catchwords that will help you as you're reading the question. Also, they'll have hemolysis so that the plasma haptoglobulin may be decreased. That could be a piece of information they give you in the stem of the question. The white count will be elevated, and certainly they'll have thrombocytopenia and petechia. And on the smear, you can see all of these Burr cells there and there and there and there. All of those are Burr cells. And the other thing you see, there's some, you can see some platelets in this one, so they don't have a severe thrombocytopenia yet. These are the complications that can occur with hemolytic uremic syndrome. Certainly we saw anemia, like I said, a hemoglobin of 5 to 9. They can have electrolyte abnormalities, renal problems, so the BUN and creatinine will go up. They can progress to oliguria. There's really no treatment except supportive care. They can have seizures. They can have intussusception, a variety of complications. Management of the hemolytic uremic syndrome is basically meticulous attention to details and supportive care, basically handling the electrolyte management and urine output. And many of these patients nowadays with good supportive care tend to have a pretty good outcome.